make sure you grab a water or a banana or a snack bar or something. We're even here to make sure you get something to eat or drink here. We'll start at 6:30 on the nose because there are people listening in, and so we record these sessions for people who can't attend, either because of geography or because of disability or whatever. So I'm Kathleen Digre. I'm a professor of neurology and ophthalmology, and I've been here at the University of Utah for over 30 years doing headache and neuro-ophthalmology. And we started this headache school a year and a half ago, almost 2 years ago, with the help of the Danielle Henry Foundation, together with the Department of Neurology here at the University of Utah, so that we could provide education for all of our headache patients and for families to understand headache and various topics. We're here, we encourage you to give us ideas about topics you'd like to hear. We have a lot of speakers here at the University of Utah that can help bring education to you. So if there's a topic you'd like to hear, let us know what it is. Tonight, and usually in the fall, we kind of have a basic introduction to headache, and that's what we're going to be doing tonight, is just headache and migraine and just talking about basic headache concepts. I don't mind being interrupted, and I will repeat your question because we have many viewers who are watching from home due to various reasons. So I'm going to start right away by telling you a story that you may not know. So anybody know who that is? Just scream it out. Napoleon. How about this one? Thomas Jefferson. How about this one? Elvis Presley. This one's a hard one. Anybody know who that is? Virginia Woolf. How about this one? She doesn't look like that now, but Queen Elizabeth. Good, very good, Queen Elizabeth. And how about this one? Whoopi Goldberg. What do you think all these people had in common? They all had migraine, every single one of them. So throughout this talk, I'm going to pose some questions and then we'll answer them together. So this is a true-false question. Are all headaches created equal? What do you think? False. So I want to bring up first, the first concept I want to bring up is that all headaches can be diagnosed, okay? We can diagnose all headaches. And when you see a provider, that's their job, is to diagnose the headache type. And we divide headaches into secondary headaches, which means it's a headache due to an underlying process, okay? It could be a brain tumor, it could be giant cell arteritis. This is a condition that's seen in older people. It could be due to high intracranial pressure in the head. It could be due to a subarachnoid hemorrhage where an aneurysm suddenly explodes and gives people a sudden onset of the worst headache of their life. But that is probably that's the small piece of the pie. That's the small piece of the pie. Secondary headaches are not very common. The most common headaches are primary headaches. And the most common primary headaches are tension type headache and migraine headache. And that'll be what we'll spend most of our time talking about tonight, is migraines, and we'll spend a little time talking about tension type headache, and then we'll talk about cluster headache briefly, because it's a very specific kind of headache. But most headaches are primary headache disorders. But you go to your doctor to get the correct diagnosis, and that's the first step in all headache, is to figure out what kind of headache you have. And how your doctor figures it out is, we don't have a Dr. Seuss machine that we put you into, and out comes you and a list of your diagnoses and your treatments, okay? What we have to do in headache, as opposed to many other parts of neurology, we have to talk to you. We have to find out what is actually happening during the headache. And so the kinds of questions that we will ask are, do you have a family history of headache? And the reason we ask that is because many of these headaches are inherited. If you ask people with migraine, for example, is there anybody in the family with migraines or headaches, they may say no, but they may say, well, my mom had sinus headaches. Well, sinus headache is usually migraine headache, okay? So we always ask about the family history. Then I like to ask about what's happened over a person's lifetime, because usually people who get migraine have car sickness as a child, maybe stomach aches as a child, and that kind of thing. And sometimes they never had headaches as a kid, but stomach aches that were undiagnosed. And then they change over time. For women, it's usually around puberty and onset of menses, where headaches really and migraines get going. And that can change with a lot of different people. Then I go after the kind of headache. And here we're talking about not just how painful it is, but here we want to know what comes with the headache. Are you light sensitive? Are you sound sensitive? Is there nausea? Is there vomiting? Do you get tearing? Do you get a stuffy nose? Do you get swelling around your eyes or around your head when this occurs? Do you get a warning sign like an aura? Because those kinds of questions will help us diagnose whether this is migraine with or without aura, this is tension type headache, or this is one of the trigeminal headaches like cluster headaches. Okay, so that's why we ask all the questions about the attack. We want to know how long it lasts, we want to know all the symptoms that come with it, and then we want to know how often it occurs, because the frequency can tell us how is this really interfering with your life. And then we always ask about these red flags. These flags are the ones that help us know whether this is a secondary headache or this is a primary headache. And that is things like sudden onset of the worst headache of one's life, or a new headache that somebody's never had before, or headaches in the face of cancer or other diseases. And we ask about weakness, numbness, tingling, other neurologic phenomenon that will happen with the headache, because that helps us know whether that could be a secondary headache. But your provider will go through all of these questions when they're seeing you. Now, the biggest question I get asked is, people come in and say all the time, well, I have tension type headaches. And I say, well, okay, why do you think that? And they say it's because on both sides of my head. But in actuality, migraines are kind of different from tension type headaches. Tension type headaches are extremely common. Almost everybody in the world can get an occasional tension type headache. It's just a little diffuse pain. It doesn't throb or pound. There's never, I repeat, never nausea or vomiting. As soon as you have nausea, you're going into the migraine category. And you never have light and sound sensitivity together. You might have a little light sensitivity but no sound sensitivity. But as soon as you have both light and sound sensitivity, you're into the migraine category. The other thing about tension type headache is it's more mild pain. It's mild to it's never moderate to severe, okay? And so And the other clue about a tension type headache is somebody can say, if I go out and run a race, I feel great afterwards. And that's more likely with a tension type headache. A person with migraine, are you kidding me? They wouldn't go running any races. They would maybe go in a dark, quiet room and sit quietly or go to bed. It's not something you're going to do. So that's more of the tension type headache. They're very common, but they usually don't send people to the doctor or the provider, okay? You don't usually go to the provider, whereas with migraine, you do. Migraine can be one-sided headache or both sides headache. It can be pounding and throbbing, light and sound sensitivity, odor sensitivity, and you can have moderate to severe pain. You can have nausea and or vomiting. Many people with migraine get dizziness or vertigo with their headaches. Almost all people with a migraine have trouble thinking. Your brain doesn't work right when you have a migraine. And it often will get worse with activity. It certainly doesn't get better. And people may need to lie down or go to a dark, quiet room or just take some time out and put their heads on their desk and rest for a while. So migraine is a kind of a different kettle of fish than a tension type headache. Any questions about that? I think it's important to understand these differences between the two headaches because a lot of people get confused about that. So sometimes people talk about the migraine or headache continuum where people can have prominent vomiting and auras and severe migraine, and then some people get just this tension type headache, and then some people can get some things that have both the migraine piece of it and the tension type headache piece of it going at the same time. And so so some headaches may have characteristics of both, but I want you to be thinking about migraine is a little bit different than a tension type headache. But some people with migraine can have tension type features. So it's kind of like migraine here is a mild generalized headache, but it doesn't cause you light sensitivity, sound sensitivity, and you're going to bed. Okay, the next question I have for you is true or false. Headache is common, but migraine is rare. Do you think migraine is rare? Anybody think migraine is a rare phenomenon? And I see a bunch of heads going no, and you are correct. Migraine is pretty common. In fact, about 20% of women have migraine. 20%, that's 1 in 5, okay? 1 in 5. Interestingly, certain types of people may have more migraine than others. For example, they did a survey of neurologists, and neurologists have a higher incidence of migraine, and headache specialists really have a high incidence of migraine. So 20% of women, almost 8 to 10% of men can get migraine. Migraine is one of the most common reasons for an individual to go to a provider, to see a doctor or a provider. It's more common than asthma and diabetes combined. Imagine that. Think about all the people you know with diabetes, asthma. It's more common than asthma and diabetes combined. It's in the World Health Organization's top 10 most disabling conditions. And the other thing is it costs billions of dollars, both in the lost income of the individual, but also in healthcare dollars. So people with migraine, it's an important understanding that it's a costly disease as well. There have been many studies about the prevalence of migraine. One of the initial studies came out in the 90s, and then in the 2000s, the migraine has been found to be very prevalent. 1 in 4 households has at least one migraine a person with migraine, and the peak incidence is in the 25 to 55 age group. What do you think about this? Headaches occur equally in men and women. True or false?
We wish.
Huh?
We wish.
We wish. The women wish it would occur equally. But the answer is false. Women are more prone to get migraine and headaches. Men can get it, but women are much more prone. And this is a graph, and across this axis is age, and across this axis is the prevalence. And as you can see, women, girls and boys kind of start out about the same for prevalence, but then as the girl has menstruation and has puberty, that incidence goes up. It does go up for men too, but for women it really goes up. And what are the years that affect women the most? It's right in between 20 and 60, kind of the most productive years of our lives, right? When we're out there trying to be movers and shakers, it's affecting us the most commonly. So I think that's something that is extremely important to recognize. And I think the other thing is that we're not alone in North America for the prevalence of migraine. This is, females are in this purple color and the males are in blue. And almost in every country, this is South America, South and Central America, Europe, Asia, Africa. You can see that in all these countries, women have more migraine than men, or more headache than men. And you can see that the incidence varies a little bit. Now, some of that may be reporting, differences in reporting. It may also be differences in susceptibility. But you can see that women definitely have more migraine than men. Here's the next question. Headaches and migraine are all in your head. And I mean, that's a little facetious, isn't it, of me to say that? But I want to point out that this is a genetically inherited disorder with a biology. I mean, we don't know all of the biology, but we do know a lot of the biology that we're beginning to understand it more and more, okay? We know that it's probably inherited. We know that it starts onset usually for women around the menstrual cycle. We have looked for genes. We've looked for a single gene, and there are some rare headache types like hemiplegic migraine that do have single genes causing it. But most of people who have migraine, they've done big studies to look for a genetic cause, and it's probably multiple genes. In fact, some of the latest data is that it's probably multifactorial genetic, and it's also got an environmental component. So it's not just genetic, but for sure genes play a role. And the other thing I think that we're beginning to understand is that it varies across a person's lifetime. You may be genetically predisposed. For example, we'll take the life history and family history of this woman. So this woman has a family history of her mother having migraines before she was even born. Then she was car sick as a child. She underwent puberty, and yep, her migraines started, okay? Then she got a job, and her migraines got a little bit worse because the job was stressful. Then she gets married, and boy, did she get a lot of headaches then. Then she has kids, pregnancy, kids, and the headaches go up. And then throughout the life, they can vary, and especially around menopause, they can get worse again. So in this menopause period of time, many women have more headaches because of irregularity of hormonal factors. And then as they get older, sometimes the headache piece will go away and an aura will continue. So isn't that interesting? So we know that it has we know that there's a genetic predisposition. We know that it has a change over the lifetime, and that change is probably biologically driven, partially by hormones, but not completely, partially by stress, but not at all completely. And so this is a typical person who has migraine. Now, I want to bring up this concept, true or false. Migraine is just a headache. Now, those of you who have migraine, I want you to answer that question right now. Is migraine just a headache?
No.
No. No. No. The answer is no. And the reality here is that individuals with migraine have more sensitive brains, and they have symptoms that go way beyond a headache alone. I gave you that list. Light sensitivity, sound sensitivity, nausea, can't think, dizziness, hyperosmia, like smells, sending people into conniptions, you know. This is more than a headache, right? This is a brain process that's going on for the individual. And we know this from a number of physiologic data. And this lecture is not the physiology of migraine. There's a wonderful lecture in our headache school by Dr. Casey Brennan, who's a professor here at the University of Utah, who goes into the pathophysiology. And if you're interested in that, he gives a wonderful lecture. I urge you to listen to that lecture. But I do want to just point out a couple things about the sensitive brain that a person has. One thing we've learned is that auras, which not every person with migraine has, and we'll talk about aura, comes out of the occipital lobe, and we think that's caused from a kind of spreading depression or an electrical change of the way the brain is working, and that gives you the visual problems. We also know that hearing is changed in migraine, smell is increased in migraine, and that this is a brain process that is occurring. And I want to tell you what about auras in particular, because a lot of people get confused about aura. An aura is a discrete neurologic process that occurs at the beginning of the headache, and usually it's visual, and the visual aura is like a zigzaggy line in the vision, and it often starts small, either in the center and goes out, or it can start out and go in. For example, this aura that one of my residents actually has migraine with aura, and many years ago he drew out his aura starting with little zigzaggy colored lines that went out all the way to the edge of their vision, and sometimes he couldn't see off to one side, and that was his aura, and it lasted about 20 to 25 minutes, and it was followed by a headache. So that's what we call migraine with aura, okay? But there are many different kinds of auras that can occur. Visual auras are the most common, and that comes out of the occipital cortex, and it gives you these wavy lines or fortification spectra or something like that. However, another kind of aura which can occur, it's not very common, is speech. People can have speech problems. Does anybody remember the newscaster who was in the middle of her newscasting, and all of a sudden she just started speaking gobbledygook, and that was an aura to her migraine. And she got accused of being drunk or something like that, but that wasn't at all. It was the beginning of her migraine, and then she had a severe migraine. Lewis Carroll, remember Alice in Wonderland? Lewis Carroll was another person with migraine, and many features of his book, like the elongation of Alice's neck, came from his own auras. He would get these very peculiar auras. Or do you remember the Cheshire Cat with his zigzaggy teeth? So Lewis Carroll was another person who had migraine. But he used some of his auras to kind of embellish what happened in Alice in Wonderland. There are other auras that can occur. Vertigo, for example, dizziness. So dizziness is another symptom that can come with migraine. It can come before the migraine and be an aura, but it also can come with migraine. And there are also other auras that people can get, where they can get numbness in their hand and their mouth at the same time, often called chiro-oral, which means hand and mouth numbness. And rarely people can have double vision or diplopia. So those are very common auras that people can get with migraine. So that would be migraine with aura. But most migraines are migraine without aura. So, yes, of course.
That tingling, is the tingling specific just to the mouth and the hand, or can
Okay.
it be other places?
The question is the tingling. Could the tingling be more than in the mouth and hands? And the answer is yes. Many people get tingling in all kinds of places with migraine because this is a sensory disturbance that occurs. It's not just a headache.
Right.
There's a sensory component to it, and it's a brain disease. It's a brain disorder. It's not just a plain headache. Okay? So I like to explain migraine this way. This is my kind of overall explanation. You inherit a brain, okay? And that brain is sensitive. You're always a little bit more light sensitive or sound sensitive. You're always a little odor sensitive. That's just the way your brain works. And I like to tell people, when you have migraine, you've got a great brain, because it's a brain that likes to multitask. It's a brain that likes to just keep on going. It's a brain that, kind of just moves and shakes all the time. It's a sensitive brain, I sometimes call it the Ferrari brain syndrome, because it's sort of a sensitive instrument. But when you don't eat is a major trigger. When you don't sleep, when you've got hormonal fluctuations for some people, when you have too much light, noise, sound, stress, etc., or closely spaced bad life events, you're much more likely to trigger a migraine. And if you have an aura from the visual aura, it comes out of the occipital lobe that can trigger the migraine, sort of migraine center, the trigeminal center. That center communicates with blood vessels, so there is a throbbing component to the pain that you receive. And those blood vessels have reciprocal pain endings in them that send back to this migraine center, so it's almost like a little circuit that starts going on. And then it relays into the thalamus and then to the brain, and the brain goes, I'm in pain. But it's not just the pain, because it's connected to a dizzy center that makes you a little dizzy. It's connected to a light sensitivity center that makes you a little light sensitive. Nausea center, which makes you more nauseated. And you can see how all these things add up to give you this process of migraine. Okay? And because it's a brain problem, this is not some peripheral little thing on your scalp. This is an actual brain disorder. So I hope I've hammered that one in, that this is a brain issue. Now, so we've got migraine with aura and migraine without aura. But here's the problem. Sometimes migraine, either with or without aura, can become chronic. And when it becomes chronic, we by definition call it chronic migraine more than 15 days a month. When it becomes chronic, it becomes really disabling. It's the part that really becomes disabling. So we have to talk about what are the factors that go into making migraines chronic. Well, they've done studies to tell us that. There are some factors we can't change. Like if your gender is female or male, we can't change that. Women are more, and females are more prone to headache. The fact that you've got a family history of migraine, you can't really change that. I mean, that's the way it is. You were born with a family history of migraine. Interesting, low education levels are sometimes associated with chronification of migraine and head injury. And you can't change the fact that you had a bad head injury. It happened, but it seems to promote people going into chronic migraine. So these are factors that you can't change. But there are a whole list of factors that we can change. And so I want to go over these because these are the ones you want to pay attention to. These are the ones you don't want, we can treat, we can make them better. And I'm going to talk about medication overuse. Medication overuse is probably one of the most common factors that promotes people going into chronic migraine, because they start taking a medicine to treat the acute headache, and it gets better, so it's kind of alluring. I'm going to take another one. And then pretty soon, you're getting a headache right from the medication you're taking. How often you get an attack of headache makes it more chronic. That kind of makes common sense, right? More headaches you get, the more you're going to get, right? And we can address attack frequency by getting people on prevention and trying to prevent them before they get out of control. How well your treatment works. If your treatment doesn't work well, your acute treatment doesn't work well, that's going to promote you taking more medications or different kinds of medications that could make it worse. If you have frequent nausea, so that you're kind of nauseated all the time, that's been associated with chronic migraine. Obesity, being overweight and obese, tends to be associated with chronic migraine. Stressful life events. I can't tell you how many patients I've seen where they said, you know, I used to get occasional headaches, but then I got this job and it was just stressful, and then I started getting more headaches and then more headaches, and this ends up being a really big provoking factor of chronic migraine. Snoring and sleep apnea, another factor that we can treat. We know how to treat sleep apnea and sleep disturbances. And then depression. And it's very interesting that people with migraine have a higher incidence of depression, and they're probably co-linked. In other words, everybody goes, well, I wouldn't be depressed if I didn't have these headaches. And I say, well, you may not have the bad headaches if you didn't have the depression. These often are very closely tied together. These are what we call comorbidities. They come along with it. And it's something we can treat. So it ends up being really important to understand these are the factors that lead to chronic migraine. I did want to just mention about taking medicines, and we'll talk. I'm going to do a little quick talk about medications, but if you take medications like an opiate more than 8 days a month, or a barbiturate, and this is something that's in Fioricet, Fiorinol, more than 5 days a month. So if you just take 1 or 2 a week, you're in danger of getting into medication overuse headache or making your headaches more chronic. Triptans, more than 10 to 14 days a month. Anti-inflammatories may be protective, and by that I mean like ibuprofen, Aleve, Advil, those kinds of medications. It may be somewhat protective, but you can even get headache from that as well. Any questions about that so far, about chronic migraine? Any questions about chronic migraine? I think it's important to understand what are the factors that make it more frequent and chronic. All right, I did want to mention cluster headache because that's a different kind of headache often seen in men. But women can get cluster too. These are different kinds of headaches, and I wanted to just mention it. It's usually severe, very severe, sometimes called the suicide headache. Unilateral, always on one side, often lasting 15 minutes up to 2 or 3 hours, and always associated with some feature like the eye gets red, the nose runs, you get tearing, you get a small pupil, you get facial swelling or eyelid edema. It's always associated with one of those factors, but it's a discrete headache type. And the reason it's called cluster is because it comes in bouts, cluster bouts, usually in the spring and the fall. And it can come with stress, and it can come with other things too. But the headache characteristic is very different from migraine. Migraine lasts anywhere from 2 to 24, 48 or more hours. And cluster headache tends to be definitely be shorter, and then have these very prominent autonomic symptoms. But it's another kind of headache disorder. Okay, any questions about tension headache, chronic migraine, cluster headache? Anything on that?
Just, what with like allergy headaches?
Allergy headaches. So sinus headache, allergy headaches. All right, here's the secret about these. If you take 100 people that say they have sinus headaches, and they've done this study, How many of those people really have sinus headaches, do you think? They are convinced they have sinus headaches. So the study answer is only less than 10%. Most of them are migraine, 90% are migraine. And here's the reason. So sinuses are right in your face, right? And everybody thinks if the pain is here and here, it's got to be my sinuses. Same thing for allergy. My nose gets all stuffy. But in migraine, you get stuffiness of you can get stuffiness of your nose. You can have pain in your face as the migraine. So most people who think they have allergy headaches, sinus headaches, they've got migraine almost entirely. Now, can allergies be a trigger? Absolutely. Allergies can be a trigger. And part of that is because of the histamines can cause vasodilation and can trigger a migraine. Absolutely, you could be triggered by an allergy. And there are people who really get bad migraines in the spring and the fall because of their allergies, but it's the migraine is the bottom line of the headache. And you have to diagnose the headache properly with the right diagnosis. But so allergy headache and sinus headache are probably not very common, truly not common. But that's a very good question.
Yeah, I'm allergic to grass back east, but I'm not allergic here and haven't had those.
Yeah, so if you're allergic to grasses and certain types of things, it may be a trigger for a migraine headache. Any other questions about migraine? That was a very good question. Okay, so now the next question I'm going to ask you is, true or false? There's nothing that can be done for a headache. Of course there's things to be done for a headache, right? So, and that's what we're going to talk about here. We're doing battle with the angel of migraine. This poor lady has just been beaten up. You know, I'm sure some of you in this room know exactly what I'm talking about. You get beaten up by a migraine. So, and I'm going to take you through kind of, to me, the most important things about what to do. First, you've got to have the right diagnosis. And by that, I mean, what kind of headache do you have? Do you have episodic tension type headache and migraine? Do you just have migraine? Do you have chronic migraine? Do you have cluster headache? Okay, you got to know those things. But that's not all you got to know. You got to know, do you have a comorbidity that's going along with the migraine? Do you have a factor that could make your headache more chronic? Because if we can't take care of it before it becomes chronic, I can tell you, an ounce of prevention is worth many pounds of cure. You know, you want to get on top of these before they're a problem. I believe in education. We here at the university and also in the Daniel Henry Foundation, we believe in education. Education is power. If the more you know, the better you do. And that's why we started this whole headache school, is that we want you to be educated about migraine and headaches. I'm going to tell you about a specific website. There are many books and everything out there, but I'm going to give you a specific one that I think is got a lot of really good information on it. And I want you to understand what's going on, because if you understand something, you can control it. If you don't understand something, what happens? You feel controlled by it, right? If you don't understand what's going on, it feels like it's controlling you. So I go, knowledge is power over the angel of migraine. The more you know, the better you do. And sometimes you have to take charge for yourself to understand your own migraines, your own triggers, your own factors that are playing into your migraines, because the more you know, the better you'll do. It's almost like a guarantee. Okay? You can get, it's good to get help, but taking charge yourself is really important. So this is a website, the American Migraine Foundation, AmericanMigraineFoundation.org, nonprofit that is dedicated itself to helping people, everybody with migraine. In this tab, you can get migraine information, and they have articles that have been written by headache experts and migraine experts, so you can learn more. In this section, they'll go through a lot of people who are willing to see people with headache. You may have to find a provider that likes to see headache. And then getting connected. This is a whole Facebook. They have a Facebook page. They have a whole blog site of people getting connected with migraine. And you can, so there are ways to join the conversation and get alerts on what is going on in migraine all the time. And it's up to date. It's continuously updated. Here's the Facebook page to try to get more help. So I highly recommend everybody to go there, join. It's a great place. So I'm going to talk now about preventing migraine, and I'm going to talk about the most important factors that I've seen in my practice and how to prevent migraine. The first is sleep. This kind of brain needs sleep every night, and needs good sleep, not just a little sleep here and a little sleep there. This brain tends to be a brain that is hard to turn off because this brain likes to think and do stuff all the time. But we've got to sleep. The sleep is the time when our brains get rid of bad chemicals and bad stuff and rearranges things from the day before. And so it's a really important time. There's a reason God has us sleeping, okay? Because sleep, and every animal sleeps. No animal is alive that does not sleep. So sleep is a biologic necessity, and we have to sleep. And for people who have migraine, sleep is incredibly important. If I was going to pick one thing that I think is the most important thing for preventing migraine, it would be sleep, getting sleep every night. The next one is stress. I can't think of a more stressful time to live in than the 21st century. We've got lights going on all the time. We got news going all the time. We got sounds. We got smells. We got smoke in the air. We got stuff going on all the time, right? And so it's a stressful time to live. And I don't think our brains were cut out for this much stress myself. I think that we have to come up with ways to sort of insulate ourselves. This kind of brain needs downtime. It needs time to be quiet. This kind of brain is the kind of brain that should go take walks every day and get out in the mountains and have some downtime, or do yoga. Like there's a yoga class after this. Exercise. I believe that people who have migraine should exercise a little bit every day. And maybe you're starting with 2 minutes and then slowly increase that activity level. Diet. And you know, lots of people go, oh, you got to be on a certain diet and all that. Well, for some people, yes, that's true. But for many people, it doesn't matter what diet you're on, you're going to still get a headache. Do you know what I mean? The main thing about food is eating regularly, not skipping meals. Because if you skip meals, many people are much more prone to get a headache. I always talk about mindfulness, and there are many websites, some really good websites out there that teach actually mindfulness and meditation and that type of thing. And then avoiding triggers. Now, there's a lot of debate about triggers because some triggers are maybe modifiable, like the kind of light you're in, like fluorescent lights versus incandescent lights, how much sound you're in, how much stress you're in, these triggers. But there's a lot of non-modifiable triggers, like a lot of people get triggered by weather changes and that kind of thing. And then some people have some foods that trigger their headaches, or, you know, red wine is a big culprit, chocolate, etc. But it's not 100% for everybody. And they've done studies where, you know, you try to avoid every trigger in the book and you still get migraine. So triggers are, if it's for you, if you have a trigger, you're going to want to pay attention to it. But that's why it's an individual thing that you have to figure out. I did want to mention that there's treatment, and I want to save some time for questions, but I want you to know that there are more treatments now than ever before, and I will just outline these. We've got a wonderful talk by Erica Marini, who's a pharmacist who goes through all the acute medicines, all the preventive medications. This is just a list of that there are many over-the-counter medications, non-specific medications. Most people with migraine should be on a migraine-specific medication to stop the headache. So when we say acute treatment, we mean when you get the attack, you should be on a medication that stops the headache. The triptans are very efficacious. They work very, very well for many, many people. And there's a whole bunch of them. So if one doesn't work, there's others to try. And if one has side effects, another may not. And everybody's individual, so not everybody responds the same way. Ergotamines are a very, very old drug and are still used in the treatment of migraine. So these are acute treatments for migraine. Then there are preventive treatments. Now, the difference between an acute treatment and a preventative is something you take every single day. And you do that to try to prevent the headache from occurring. And the acute treatments are ones you just take when you get the attack, at the onset of the attack. Now, preventives are in many different classes of drugs. One of the most efficacious class are anticonvulsants, valproate, and one that a lot of people like, topiramate or Topamax. I'm sure you've heard of that one. Sometimes antidepressants are very helpful, especially the tricyclic antidepressants, because they help with sleep. Occasionally, the other antidepressants work, especially if people have comorbid depression. Beta blockers have been around for many, many years, are very good at preventing migraine. One of the classic ones is propranolol or Inderal. Calcium channel blockers like verapamil, non-steroidals like naproxen. One drug used a lot in children is cyproheptadine. And there are vitamins like people have been on vitamin D, etc. for migraine prevention. There are herbal products that people have tried and even some minerals. And one of the drugs that's been approved by the FDA for chronic migraine is onabotulinum toxin, which is injectable, sometimes known as Botox, onabotulinum toxin, but it's been approved by the FDA for migraine. Okay, there are new medications out there. How many of you have heard of the new calcitonin gene-related peptide monoclonal antibodies? Okay, how many of you have tried it? Well, okay, a couple of you have already started trying it. This just came out at the end of May, beginning of June. We've had some trouble getting everybody on it, but it was just approved by the FDA. These are injectable antibodies to the calcitonin gene-related peptide, either the receptor or a ligand, but it's one of the pain transmitters. It's a transmitter of pain to the head and face. And there's a whole bunch more that are set to be released. Galcanezumab, fremonizumab, and eptinezumab. And the one that was just released is Arinumab or Amavig. So that's the one that just came out. But these are new medications that have just come out. So I think, and there's many more on the launch pad of different types of medications that are coming out. Designer drugs for migraine, in a sense. And then there are a bunch of devices. And we have a lecture on devices in headache school. If you're interested, Dr. Ozeder-Grew went through all the devices and showed them. But there's the Cephaly device, and they're all FDA approved. The transmagnetic stimulation, which is a magnetic pulse to the occipital lobe, often at the onset of the aura, but also approved in migraine. And then the vagal nerve stimulator for the initially approved for cluster headache, but now approved for migraine. So these are devices that are out on the market. But I don't want to forget non-medication things like relaxation therapy, biofeedback training, cognitive therapy. If there's a lot of stress in your life, getting stress under control with working with a counselor or a therapist. And then there are some potentially effective treatments like acupuncture, transcutaneous nerve stimulators or TENS units have been used. And there is evidence in the literature for many of these devices, these treatments as well. So headache is common. I hope I've convinced you. Headache is common, migraine is common, and you've got to get the right diagnosis, right? You have to have the right diagnosis, because if you don't have the right diagnosis, then you don't know what you're treating. And a diagnosis isn't just the kind of headache you have, but the diagnosis is also, are there other things that are contributing to the headache that are making it worse? It can be disabling. Migraine can be disabling, and we don't want it to be disabling. We want everybody out working and living their lives. Education is essential. I think anybody who has headache, education is where it's at. The more you know, the better you do. And remember that treatment is always possible. There are more treatments now than ever before. You know, if I stood up here 10, 15 years ago, I wouldn't have had as many things to say tonight. But now we have a lot of things out there, and it's a time, it's kind of we're in a wonderful time of a lot of exciting science that is driving new treatments that are coming down the bend to help everybody who has headaches. Well, the last question I have for you is, who is this? Does anybody know who this is? So this is St Dymphna, the patron saint of migraine. And she's holding a very learned rabbit on a person's head. I wish it were that easy, right, to put a rabbit on your head and have your headaches all go away. But I think the message she's trying to give us is there's always hope, and you can't give up. And you don't want to let the world of headache get you down. You want to be able to take that world of headache off your head and have it under control. So in the last 5 minutes, 7 minutes here, I wanted to open it up, because the other part of this whole thing that we have for Headache School is that nobody goes away with a question, that they get their questions answered as well. Any questions about what we talked about tonight? Anything you always wanted to know about migraine?
I think I've moved into the chronic headache category.
The chronic migraine category?
Right. Probably because I'm in pain a lot and take medication. Is there a retreat from that?
All right. The question is, what do you do if you're getting into medication overuse headache? And the answer is, we're not sure what the best treatment is. But we do have a study ongoing here at the university, which is in medication overuse headache, and we're randomizing people to stopping the medicines cold turkey versus starting a preventative and just letting the patient stay on their medicine and keep going. There are many schools of thought on this. There are some people who believe, get somebody on a preventative that starts to prevent the headache, and then the medication overuse will go away. Because the reason you overuse is your preventative is not working right. And so that's one school of thought. Another school of thought is, until you can get off the medicine, you can't get the medication overuse headache out of under control. And I think the answer is probably in between. I do believe you have to find the right preventative to start preventing headaches, and remember all those comorbidities that can kind of come with this, like sleep disturbances and stress management and all the things that come with this. If we don't deal with that, it doesn't matter if we stop medicine, it's still going to keep making these migraines more chronic. So I think it's difficult. There are different ways to stop. I mean, one is to stop cold turkey, another way is to taper. Sometimes what we do is we say, okay, you're taking a triptan every single day. Well, then we say, well, why don't you take a triptan once a day, not twice a day or 3 times a day, but once a day, and then try to wean off to every other day, and then try to wean off to every 3rd day, and then try to slowly come off. I mean, there are many different regimens that you can use. Sometimes I change the triptan. I go from a short-acting triptan to a longer-acting triptan, and sometimes that works. You can do like 3 or 4 days of a longer-acting triptan, try to break the cycle, and then start all over. But get the prevention right. Another way to do it is we have had people come in, stop the medicine they're overusing, and then treat their migraines acutely with a different class of drug completely. Trying that. There are just many different ways to do it. Some people put people on steroids, like prednisone, and do a prednisone burst and taper, kind of an anti-inflammatory, and then come off the overused medicine. But there's no right way. It's always a little bit where you have to work with your provider to come up with the right way for you. And the study that we're doing here at the university is trying to look at it does stopping it cold turkey and getting a preventative and stopping cold turkey work, as well as coming up just putting them on a preventative and then see what happens. Do you know what I mean? And continue using it and try to find a preventative that works. Yes?
Is that the study that is in the papers out on the...
I don't know. I'd have to look and see which paper is on the table out there. But if you're interested in being at it, you can give me your name and we can talk to you further about it and see if you're a candidate to come in for that study. But it's a study funded by the government that wants to know. It's a PCORI study, and it's funded, and people want to know what's the best way to do this. It's a hard question. You asked a very hard question because we don't know the right answer about medication overuse. It's very difficult. Any other questions? Yeah.
When you say regular meals, how complete should each meal be?
Okay, the question is, when I say regular meals, how complete does that have to be? Well, the answer is kind of variable from person to person, but I've got some people in my practice that they have to eat every 2 hours or they're going to get a headache. That's how so they usually cut up a protein bar into pieces, and about every 2 hours they take a piece of a protein bar. You don't want to do carbohydrates because that is pretty much a flash in the pan. But a protein bar can be very helpful for some people. Now, some people can fast ad nauseum and never get a headache. Like, they can go fast, and there's some people who really have to eat absolutely regularly to keep their headaches under control. So that's another one of these individual variations, and that's why it's so important for every individual to learn about their own headache, take charge of themselves, understand what things are really coming into play, because no two people are the same. And I can tell you, it's not like a cookie cutter that I can just say, oh yes, you just do this and everything is fine. It's totally independent, dependent on the person and the individual. It's a hard problem for some people eating regularly, especially if they're nauseated a lot. That makes it even harder. Any other question? Yeah.
Do you have any advice relating to headaches caused by a damaged facial nerve?
Advice caused of headaches caused by a damaged facial nerve. And it depends on what kind of damage was done. If it's a damage to the sensory nerve, like the trigeminal nerve, that's a little different than if it's a damage to the nerve that makes the face move. Those two are kind of different. But people, if it's a problem with the whole face moving, one problem happens when the whole face doesn't move is the person doesn't blink completely, so the eye gets sore and red, and then that can trigger more headaches because there's pain coming in that way. If it's a damage to a nerve that's a sensory nerve, that's a lot more tricky because that means that you can get spontaneous pain coming from that nerve all the time. And that often takes some specialty thinking to try to get that under control. Sometimes anticonvulsants work better for that kind of face pain. But those can be tricky. But that's where I would probably work with a provider that knows a little bit about injuries and facial nerves and things like that. Any other questions? I don't want to take into the time of yoga because our yoga instructor is here, but I want to thank you all for coming to Headache School. We urge you to sign up if you've not signed up so you can get updates on when we are, what lectures we have. We want to hear from you. Let us know what topics you want to hear because we're here to provide you expert information to help you and the journey of having headaches. And it's not just you that we're trying to help you and your family because often this is a family disorder. It affects everybody. And so we want to make sure that we're here for everybody and answer all your questions. So thank you so much for coming tonight, and we look forward to seeing you at our next Headache School, which is in September. And the schedule is out there already. The September schedule is all out there already. So thanks a lot for coming.